Hi, so today our topic is going to be transfusion reaction. A transfusion reaction is basically an adverse immune or maybe non-immune reaction that occurs after receiving a blood transfusion. So sometimes they are caused by antibodies, while other times they are because of inflammatory mediators or just volume overload. So first we have allergic or slash anaphylactic reaction, right? So this is going to be a type 1 hypersensitivity reaction against the donor's plasma proteins. Okay, so let's say this is the donor, right? And this is the recipient. So it's just basically that the donor's blood has some of these plasma proteins, right, that are present that the recipient is allergic to. So this case is especially seen in IgA deficient patients. So what happens is that the IgA deficient patients develop IgE antibodies that are against IgA, right? So this is an IgE antibodies, right? And it is developed against IgA. So it makes sense that this IgE is from the recipient and this IgA is present in the donor's blood. So what happens is that the patient who is receiving the blood, the recipient, he has what are known as anti-IgA IgE antibodies. Okay, so I'll go through this again. Anti-IgA, so this is IgA, they have anti-IgA IgE antibodies. So basically IgE against IgA, right? Now what happens? When the donor has the IgA antibodies in its blood, the recipient senses them and it develops IgE antibodies, right? Now what happens? The whole mechanism of type 1 hypersensitivity takes place. So those IgE antibodies go ahead and attach themselves to the mast cells, right? And upon re-exposure to IgE, right? So let's say this is again an IgE molecule. So they cross-link and this leads to release of histamine, right, of histamine and other inflammatory mediators that I talked about in type 1 hypersensitivity. So there are anti-IgA and IgE antibodies that can cause anaphylaxis when they are exposed to the donor's IgA. And this occurs within minutes to few hours after transfusion, right? Because it's a very acute reaction. So the symptoms are going to be the same for type 1 hypersensitivity, such as urticaria, wheezing, edema, shock, bronchospasm, right? All of those. And the treatment is to stop transfusion immediately. And then because it's a histamine mediated reaction, so you give antihistamines if the symptoms are mild, right? And you give epinephrine if the symptoms are severe. So next we have acute hemolytic transfusion reaction. This is going to be your type 2 hypersensitivity. And can you recall what is type 2 hypersensitivity? It is basically antibody formation against your body's antigen or tissues. Now in type 2 hypersensitivity, there is ABO incompatibility. So ABO are blood groups, right? These are antigens. These are major antigens that are present on your red blood cells, right? So let's say this is someone who is A positive. Okay, so let's say this is someone who is A positive and they have the A antigen on their red blood cell. So if they have the A antigen in their red blood cell, so obviously they will have anti-B antibodies. Okay, so these are going to be anti-B antibodies. So they will attack any red blood cell that has the B antigen, right? So if this is the red blood cell that has a, let's say, the B antigen, so it will attack this, right? And this is what we always have to take care of whenever we are transfusing someone with a blood. That's why we ask for their blood groups, right? Because we don't want this reaction to happen and it's really severe. Now what happens is that there are preformed recipient antibodies and they're either IgG or IgM against the donor RBCs. So let's say that our recipient is O positive, right? So let's say they are O positive. So obviously they will have antibodies against A and against B both. So when they get transfused with, let's say, with A blood group, right? So let's say they get transfused with A blood group, this antibody will attack these red blood cells, right? So that's what we don't want. And this occurs during transfusion or within 24 hours, right? And the symptoms are going to be very non-specific symptoms such as fever, chills, and there are also going to be hemolysis signs. The reason being because obviously, like I said before, you have antibodies that are against the RBCs. So hemolysis signs are going to be stuff like hemoglobin urea, right? Because when you have increased hemoglobin in the blood, it comes out into the urine. And there's also going to be Coombs test positive. So what is Coombs test? I've talked about this before. The one thing that you have to know regarding Coombs test is that what you are checking is there antibodies against the red blood cells. If there are, then the test is positive. If there are not, then the test is negative. So like I said before, Coombs test is positive, and this tells us that the antibodies are attached onto the RBC surface. And then the hemolysis labs will also be positive. Now, what are hemolysis labs? So they are increased LDH, lactate dehydrogenase, right? It's a very non-specific enzyme, but I have seen this mostly being used in the context of hemolysis. So the red blood cells, right, whenever they get hemolysis, they release LDH into the bloodstream. So that's why we see increased LDH. And then increased indirect bilirubin. So bilirubin is basically a breakdown product of porphyrin rings that are present in your hemoglobin, right? So obviously when you have lysis of the red blood cell, you're releasing hemoglobin into the blood, and in turn you are having increased indirect bilirubin in the blood. And along with that, we have decreased haptoglobin. Haptoglobin is a molecule that is present in the blood. What it does is that it basically attaches itself and binds on to free hemoglobin that is present in the blood, right? So what happens is when you have hemoglobin released into the blood in very large amounts, such as in the case of hemolysis, haptoglobin binds onto the hemoglobin, and what happens is, since it's in very huge amounts, the haptoglobin will be used up or consumed, and that leads to decreased haptoglobin that is seen in the blood. And obviously the treatment will be to stop the transfusion and start with supportive care. Okay, so next we have febrile non-hemolytic transfusion reaction. Now this is going to be when the blood that you take from, let's say, a donor, and then you store it for a long time, right? What happens is that the donor WBCs that are present inside the stored blood, they start releasing cytokines, right, while being stored. So when you take that blood and you transfuse them into another recipient, what happens is that those cytokines, they can cause fever in the recipient. So, and it occurs mostly 1 to 6 hours after transfusion. It presents with very non-specific symptoms like fever, chills, and weakness. But like I said before, there is no hemolysis. The reason being because there are no antibodies that are being formed. And since there are no antibodies being formed, Coombs test will be negative. And when you look at the labs, you will not see increased LDH, you will not see increased indirect bilirubin, you will not see decreased haptoglobin. The reason being because there is no hemolysis. Now, how do we prevent this from happening? We do what is known as leukoreduction of blood. Basically, we make sure that the blood that we are taking from a donor, we remove the leukocytes that are present in it. Okay, next is a very high yield condition, right? And this is known as transfusion related acute lung injury, or TRALI, right? And I'm going to try to make it as simple as possible. So what happens is that in the donor, there are going to be what are known as anti-leukocyte antibodies, okay? These anti-leukocyte antibodies bind to the recipient's neutrophils in the pulmonary vessels. So let's say this is the donor and this is the recipient. What happens is that the donor in the blood, they have what are known as anti-leukocyte antibodies. So these are anti-leukocyte antibodies. What happens is these antibodies go into the recipient and they attach themselves to the neutrophil. So let's say this is a neutrophil in the recipient. So they attach themselves to the neutrophil. What happens is that the neutrophils get activated. And it is this activation of neutrophils that they start damage to the lung endothelium. They start damaging the lung endothelium, right? And like I said before, they are since they are present in the pulmonary vessels, they start damaging the lung parenchyma. And this leads to what is known as non-cardiogenic pulmonary edema. So mostly whenever you get a question regarding pulmonary edema, one of the high yield causes that we always think about is going to be heart failure or heart problems. But in this specific case, there is no cardio cause. It is specifically because there's damage to the lung parenchyma that we are seeing edema, right? And this occurs within 6 hours. So from 0 to 6 hours, TRALI can occur, right? The reason why I'm stressing this 6 hours time period is because greater than 6 hours is going to be another condition that I'm going to talk about. And like I said before, it presents similar to cardiogenic pulmonary edema, right? So when you do a chest x-ray, you will see what is known as bilateral infiltrates, right, on chest x-ray. And when you see the chest x-ray, is going to be very hazy pattern and a very diffuse hazy pattern, right? But like I said before, there are no heart problems. Okay, there are no heart problems. And how do we treat them? Well, we cease transfusion and we start supportive therapy. So if they have very severe lung damage, we put them on ventilators and we make sure that the damage subsides. Now, diuretics, right? Diuretics are basically drugs that are used to decrease volume inside the body. So obviously the diuretics will be ineffective. Why? Because it's not a fluid overload state. There is no increased fluid volume inside the body, but rather there is damage to the lung parenchyma. It is the damage of that alveoli interface with the blood that leads to leakage of fluid inside the alveoli, and because of that there is pulmonary edema and breathing problems. Okay, so that's what really goes on. Now contrast that to what is known as TACO. TACO is also known as transfusion associated circulatory overload. Now this is cardiogenic pulmonary edema, right? So this is going to be due to a cardiac cause. Pulmonary edema due to a cardiac cause. So it is due to volume overload. It is due to volume overload caused by blood transfusion. Now normally this is not a huge problem and it's not very evident, but it is especially evident in patients who are at risk. So who is at risk? They are going to be elderly and infants. The reason being because their hearts are weak and they cannot handle that much volume that is coming in, right? Or patients who have a pre-existing cardiac or renal dysfunction, right? So patients who have renal artery stenosis or long-standing like heart failure or cardiac problems like MI, right? So people who have a cardiac or renal problem, or rapid transfusion of large volumes, right? So what is the pathophys over here? So there is excess volume, right? There's excessive volume and the heart cannot pump that excessive volume. So what happens is that there is increased hydrostatic pressure that develops inside the capillaries because of the excess volume. And because of this, fluid starts leaking into the alveoli, right? And that leads to the pulmonary edema. And by the way, this is also the mechanism of how heart failure can cause pulmonary edema, right? Because let's say that this is your heart, right? And let's just divide this. Okay, so this is left atrium, this is left ventricle, this is right ventricle, this is right atrium. So what happens is that when from the right ventricle you send the blood to the lungs, right? And then from the lungs they come back into the left atrium. So let's say you have heart pumping problem, right? So if you have a heart pumping problem, what happens is that the blood, instead of being pushed from the left ventricle to the body, it backs up. So it backs up, it starts flowing in reverse. So from the left ventricle, it goes into the left atrium, and from the left atrium, it goes into the lungs. And in the lungs, because of the increased hydrostatic pressure that is building up, that leads to the fluid leaking inside the lungs and leading to pulmonary edema, right? And one more thing. I talked about the left atrium right now, that the blood backs up into the left atrium. Something that is known as PCWP, pulmonary capillary wedge pressure. I'm not going to go into many detail, but just all you have to know is that pulmonary capillary wedge pressure is basically measuring the pressure inside the left atrium. So if you have increased pulmonary capillary wedge pressure, that obviously means that there's increased amount of blood inside the left atrium, right? And because there's increased amount of left atrium, so because there is increased amount of blood in the left atrium, the blood backs up and starts leaking into the lungs, and that leads to pulmonary edema. So it's one of the ways that we measure whether the patient has a heart failure problem or not, right? So PCWP. And like I said before, it occurs after 6 hours. So 0 to 6 hours is most probably going to be Trali, right? After 6 hours is going to be Taco. So that's what you really have to know. And by the way, pulmonary edema usually presents with like dyspnea, breathing problems. And by the way, another thing, heart failure symptoms are going to be present in TACO patients. So there are going to be symptoms of heart failure. Now, what are the symptoms of heart failure? There is going to be like JVP, right? So increased JVP, jugular venous pressure, okay? So when you observe their jugular vein, it will be very prominent, okay? I'm not going to go into the mechanism as to how that happens, but just know that their jugular veins become very prominent. Another thing that you see is that they have a lot of problem with lying down, or basically they cannot sleep at night, right? They cannot go into a complete prone position. Why? Because blood is obviously dependent on gravity, and when you completely lie down, what happens is that blood that is present in your heart, right, that cannot be pumped out, right? So because of that, they start having a lot of breathing with they have a lot of difficulty with breathing, okay? So, and along with that, obviously when you take a chest x-ray, you will see a dilated heart, right? And there are many other points that I need to talk about, but just know that increased JVP is one of the most prominent signs of heart failure. And obviously the treatment is going to be to stop the transfusion and start diuretics. The reason being because you have an excess volume state. There's an excessive volume state, right? You want to make sure that that volume gets out of the body, and you can do that by starting diuretics. That's one of the reasons why whenever we have a heart failure patient, we want to get them started on diuretics, because we want to aggressively remove that excess volume, right? And one of the examples of a very strong diuretics that is used is going to be furosemide. Furosemide is one of your looped diuretics, right? So it acts on the loop of Henle, and it acts on what is known as the sodium potassium 2-chloride transporter. I'm not going to go into the detail, but just know that it's a very important drug that is used. And obviously that leads to fluid loss and basically betterment of the symptoms for the patient. Okay, finally, we have delayed hemolytic transfusion reaction. It's again going to be a type 2 hypersensitivity reaction, meaning that there's antibody formation against an antigen, but this time the antigens are minor RBC antigens, not the major RBC antigens, which were basically A, B, and O, right? So these are minor ones. So if there's a mismatch in minor RBC antigens, the symptoms are not going to be as severe as with the major ones. The symptoms are going to be mild and self-limited, right? And the reason why this happens is because there's production of low levels of allo antibodies. Allo antibodies are antibodies that are produced by your immune system in response to a foreign antigen, right, from an individual of the same species. Okay, so there is production of low level of allo antibodies from prior exposure, and upon re-exposure you have IgG formation that leads to hemolysis. The reaction occurs 24 hours after the transfusion.